So, hello everyone. On behalf of EuroELSO, it's a great pleasure to welcome you to a new edition of the EuroELSO webinar series. Today we have a great topic and great speakers who will present actually the brand new working group for infections in ECMO care of the EuroELSO. And it's not only an opportunity to deal with the topic that every one of us is dealing with on a daily basis with our patients, but also to get to know the group, what their plans are, and if you want to get connected and how we can take the maximum out of it together as clinicians and scientists. So today as a first speaker, we have Jordi Riera, who's also leading the working group from Barcelona. Then we have Marta Hernandez-Meneses, also from Barcelona, and Stephanie Thomas from Manchester, UK. And once again, thank you to our experts for making themselves available today and for speaking to us. We are very excited. And Jordi, this is your word. Please take over the presentation. Thank you.
Thank you a lot, Peter. Hi, everyone, wherever you are. Please enjoy this webinar. It has an intention to be bidirectional, so we are here to get your questions probably at the end of after our talks. And thank you, Peter, for inviting us in collaborating with in these very important webinars, because we work with in a context full of doubts and uncertainties, and this network is very important. In this today, related with infectious processes, in the patient receiving ECMO support, and I will start talking about definitions and impact. And now I will share my screen in hopefully few seconds. Okay, here it is. Okay, Peter, can you see my screen? Okay, so I have taken the liberty, with the permission of the wise moderator, to change the order of these two entities. I will talk firstly about definitions, and it will take the 70% of my presentation, and then about impact. And now today we are talking about infection in patients with extracorporeal life support. Some disclosures, maybe these would be related, but don't be. It's a clean presentation with no interactions between. It's only science and scientific networking. So first, I will describe the scenario at focus, which is here, right here, the clinical scenario of a patient receiving extracorporeal life support, receiving ECMO support. This is the most critically ill patient at our ICUs. It's a patient with massive respiratory or circulatory failure in whom the conventional measures have failed. So, and the first thing to say, this is full of complexity, but I don't have time to go into the details. I'll leave it there. This patient has severe immune dysregulation. In very brief summary, due to the inherent pathological condition of the patient, and also for some degree of relative immune paralysis, immune paresis, provoked induced by the proper ECMO system. And this should be taken into account. We are going to analyze the aggression, but we should take into account that further the patient has problems in the war against this aggression. And you can see here how complex is the scenario. The patient is, how much instrumentalized is the patient. You can see it here, you know it. You have been beside these patients, and this patient is at high risk of developing nosocomial infections. And I have included, and I would like to share with you, these relevant structural details that would be, to me, are very linked with this high risk of developing nosocomial infections. First, the blood is exposed for a number of days, several days in some patients, to different surface here. So the coagulation process is stimulated, and this network is created. I know the new systems are very biological friendly and biocompatible, but still you find some clots existing in the system, because the system triggers the two mechanisms of defense of the patient, which is inflammation and coagulation. And this context is perfect for the accommodation of pathogens. Two events, coagulation processes and inflammation processes, that are very linked and linked with an infection aggression. Okay, this should be taken into account. Also, within the system, you can see here, you find some areas of turbulent and slow flow, which are at higher risk of developing clots, and so accommodation and adhesion of pathogens inside the system. Further on, importantly, we have large cannula from which we take the blood and through which we return after oxygenating the blood to our patient. And they are normally inserted via the Schellingowski technique, but other patients, or in other clinical context, we insert this large cannula through a semi-surgical approach, or even in this patient, for example, with an open chest, directly, central cannulation. And this, for sure, this patient here, up here at the right, upper part of the screen, is for sure at higher risk of developing nosocomial infection than, for example, this patient maybe breached to lung transplant with a double lumen cannula. Okay, so this should be for sure taken into account. And we have a problem here if we have an infection here. This is not the same as CVC regular line. That, for example, here we change it and we put a subclavian. If you have a large cannula, it is very difficult, in some cases impossible, to change these lines, this large cannula. And this is a new scenario we are facing. Also importantly, have a glance here. Entering the gas interchanger, you have a gas source, normally full of oxygen, and this chamber is not sterile. It is separated. It is separated from the blood by you know it very well, by a polymethylpentane membrane, but it should be taken into account. Similarly to what happens with the heater cooler. With this machine here, we are heating normally the blood. You can cool also the blood, but you can change the temperature of the blood before re-entering again the body of your patient. And this is not in direct contact with the blood, but this is not a sterile chamber. And this also should be taken into account. Also in the system, we have connectors, and we frequently take samples to perform tests, anticoagulation tests and biochemical and so on. So we enter the system, we take blood frequently from the system, and further on, we connect devices such as the extracorporeal renal support directly to the system. So all these aspects are related with this higher risk for developing nosocomial infection in the patient receiving ECMO support. So this patient in this complex scenario could develop habitual traditional nosocomial infections in the critical patients, such as ventilator-associated pneumonia, urinary tract infection, CVC line infection, and also could develop ECMO-related infectious processes. And we have new actors on the scene. We have new entities, and regardless, this possibility, regular, traditional infectious processes, and these new actors, and this might be for sure one of my main messages. There's a difficulty in finding a valid definition for these entities, okay? Let's see the traditional nosocomial infections criteria in the clinical context of an ECMO patient, okay? So systemic, clinical, habitual manifestation of an infectious process, such as fever, might be present or not in an ECMO patient because we have the heater cooler. We are changing the temperature of the patient. So you don't find in a patient with ECMO support developing an infectious processes. It's not common to find very movements or important movements in blood in body temperature. You may find some small changes in temperature. You can find them, but it's not. You can't assume this is a general response of an infection in the patient receiving ECMO support. So what about analytical findings? Normally, in the conventional critical inpatient associated with an infectious process, such as changes in the leukocyte count, in CRP, in PCT, well, we have said that the system triggers inflammation, so it can be a confounder, and you don't really find these changes normally in the patient with ECMO support who is developing an infectious process. And what about other means of diagnosis infectious processes, such as, for example, in ventilator-associated pneumonia, new consolidations? You can see here, up here, the chest X-ray of an RDS patient receiving ECMO support. How can you identify here new consolidation? It's very, very difficult. Further on, the gas interchange impairment normally found in a patient developing pneumonia, as you have the ECMO system, it's very easy to compensate this. And it's difficult to be found this gas interchange impairment. So I would say that one of the pillars, and this is another important message for you, in diagnosis and infectious process is based in microbiological findings. And I know there's microbiologists here in this call, and they are essential. We have a direct contact with them in our center because they are very important professionals in taking the decisions, the clinical decisions related later on with the evolution of our patients, okay? But this is only one pillar. It's not the only one, because we have to differentiate. This is a contamination, maybe. This is a colonization, or this is a pathogen which is creating an infection. So we should combine this pillar, microbiological findings, with clinical manifestation, and I would say the other pillar is local signs and symptoms of infection. These local signs and symptoms, if we are talking about respiratory infections, change in secretions, increase of secretions, change in the quality of secretions, change in the color, etc. If we are talking about urinary tract infection, the presence of pyuria, can be a good marker of something is going wrong there, and you have a positive culture. This combination should be reasonable to diagnose an infectious process in a patient receiving ECMO support. What about catheter and also cannula, the insertion site erythema, or even purulent secretion? This is local signs of infection, and I said signs and also symptoms. We should take into account this. We recently diagnosed urinary tract infection in a patient here in our unit. She was awake, no signs, no change in the variables, in the blood pressure, in the heart rate, etc. Leukocytes, same. And she told us, I have pain down there. So we took a sample, Escherichia coli, 3 days of antibiotics, solved. Imagine this patient being sedated, so pain as she sedated, no possibility of communicating with us, then fever, then sepsis, and then you put the antibiotic. So this is another underrated, I would say, characteristic of positive effect of awakening the ECMO patients, but this for sure is another story. And I put an asterisk here in systemic manifestation of an infectious process, because we feel that seeing a lot of patients, some systemic hemodynamic changes are seen in patients developing infectious processes, specifically tachycardia and hypotension, especially in VV ECMO patients, but also veno-arterial patients. This is very unspecific. We are talking about heart rate and blood pressure, but it should be taken into account. And for sure, you have to do the differential diagnosis with hemorrhagic complication of your patient. Okay, I think this is a very important slide. But we have, again, new actors on the scene. We incorporate the extracorporeal device, very in contact with the blood of the patient and with a large foreign surface during days, at risk to be conquered by pathogens. And we can divide the structure of the system. We have the oxygenator or gas interchanger, usually wearing connectors. You can see it here, here and here, here and here. So this is important, I would say, because you can take blood samples to culture and to see what is going on there, like quantitative, cultures from there. So, similarly to a CBC line. Also, you have the pump here that I would say is another structure in the system, but I would say it's not so frequent to have accommodation of bags here. You have the tubing, and especially the areas of turbulent and slow flow are at risk of pathogen accommodation, but especially at the oxygenation, I would say, all over the circuit, and also the connectors that I always recommend to put the less number of connectors as possible in the ECMO circuit, but you need them to take samples and so on. This is another topic. Another important component is the cannula, the cannula. And we should differentiate, I would say, drainage cannula from return cannula. The drainage cannula is surrounded by negative pressure and also inside the cannula for sure. And the return cannula is surrounded by positive pressure. And I would say this has an important role. I don't have evidence to share with you, but I would say also related with clotting would be more frequently to find them, and this clotting and consequently areas of risk for pathogen accommodation in the negative pressure than in the positive pressure. And further on, in the positive area, maybe you are at higher risk of embolism, of clots, and also of pathogens back to the patient. So I would say it should be taken into account. But this is only an hypothesis, okay? It's very important, and there's great evidence related with other clinical contexts, is this here, which is seeing the hole through which the cannula is going to the patient. You have to see this. You can't cover this. You should cover this with aseptic structures, but they should be transparent. You should see this because we are talking about local signs of infection, and it's not good for the patient, for prevention of nosocomial infection, to cover this with a structure through which you can't see the holes. So this should be visible. And then when you retrieve the cannula, they can be analyzed, microbiological. Here in Barcelona, we started to do MACI several years ago, but finally, talking with the microbiologist, we changed it to sonication, so we can explore the biofilm of the cannula, and that's what we are doing. I will share it with you in some slides. And also, other structures, I have already said, the heater cooler. It has water. It's not in direct contact with the oxygen, with the blood of the patient, but some publications has been released saying we have analyzed this water and we have found mycobacteria here. For sure, later on, Marta will talk about this. And also the air chamber. This is fairly unexplored. There's a air chamber which is unsterile, going to the oxygenator, but again, it's not in direct contact with the blood. But for sure, a priori, it should be also taken into account. So, to diagnose an infectious process related with these structures, this is key point for sure. This is the microbiological finding for sure, but it should be combined with some clinical information, because we have to differentiate. If you see a staph epidermidis, this information is important for sure, but what is important for the patient is if this bug is only there, or it's maybe a contamination. This should be taken into account also, or maybe this bug is creating infection. So we have to combine this microbiological information with something that we will explore in some slides. Okay, we can establish this definition, ECMO device related infection, but we will have a problem, especially with the cannula, because you may have a bug there infecting the cannula and the incisor site. We have in some days ago, and we have a patient with infection site, cannula site infection, and you can't in some patients you can't change this cannula, and normally you can't. It's not easy to ensure a source control, which is one of the most important steps in solving an infectious process. And this complexity should be taken into account in this relatively new scenario of a critically ill patient receiving ECMO support. I would like to share with you data from a study, not very detailed data, but some data which may be of your interest, derived from our study, Riera study we are doing here in Barcelona. It's a prospective study, not going into the details, including all the adult patients receiving ECMO support. Okay, it's a prospective. What we are doing is we are doing a registry of all the positive cultures, and the cultures are taken by decision of the clinician. Okay, the clinician decides, okay, I suspect an infection, I take a culture, okay, we register this. And also at this very time point, we take the clinical information, and we will get together this information and see which is the relation between this microbiological information and the clinical manifestation. Not only at this time point, but also 24 hours before. And this is another important message for you. Regarding the clinical information, it's suggested to take the delta, the change of the parameters of the temperature of the CRP, of the PCT, especially if the system itself triggers procalcitonin and CRP. Okay, so the delta information, and we will analyze this, getting together this microbiological information and the clinical information. Also, in a circuit change, what we are doing is taking peripheral blood cultures. We take blood samples from the system, pre-ox and post-ox, and then this old system, we recirculate the system for some hours, and then this liquid inside the system, we culture this liquid, and for sure, we take the clinical information at this time point and 24 hours before, and we will get together this information and see which is the relation between these findings, because we find interesting, you can see it here on the screen. It's in Spanish, but it's easy to be understood, especially the names of the germs. Epidermidis, and we see some relation between, okay, this priming liquid, positive for staph, we go there, leukocyte up, some fever, and so on. Okay, that's only some non-detailed information, but for sure it would be interesting for some of you. Also, we stopped taking the samples from the pre-ox and post-ox because we analyzed a number of patients and we found same information. So maybe if you are trying to do this with one sample from the oxygenator is enough, okay? And when we decannulate the patient, we do the same, peripheral samples, blood samples from the circuit and analyzing the priming liquid. And also we analyze the cannula by sonication. And we will analyze this together with the clinical information at this time point. Hope this has been interesting for you, this information. What about the evidence regarding the definition of these infectious processes in the ECMO patient? What about the literature? Well, this is a publication from the group of Graham and team who reviewed the literature, okay, focusing on the incidence of nosocomial infection in neonatal, pediatric, and adult population receiving ECMO support. And they found, they reviewed a number of studies, seeing a lot of heterogeneity in the incidence. It goes from 10 infectious events per 1,000 days of ECMO to 116. Again, it's neonatal, pediatric, and adults. But it's very heterogeneous. Why? Because especially or mainly because of this, of the absence of an homogeneous definition of an infectious process. Also, not only not due to this, also related with the heterogeneity of the populations included in these studies. It is not the same veno-arterial in a post-cardiotomy with an open chest than an ECPR or a VA ECMO support stabilizing an arrhythmia. It's not the same patient. And sometimes in these studies, they put in the same box and it's difficult to be analyzed due to the heterogeneity of the population, but especially these changes in the incidence between studies is due to this absence of a well-defined definition for nosocomial infection. And also due to the variability in the management of patients, the prophylaxis, the microbiological surveillance, and infection control policies. But this is due to the absence of a well-defined definition. This heterogeneity in what we do. I do prophylaxis with antifungal, and I cover positive gram cocky, and I cover etc. Okay, this heterogeneity is due to the absence of a definition. So it's very important to do an effort to find a definition. If we analyze this publication, I would say this is one of the most important from Bizarro and colleagues. Several years ago, 13 years ago, in analysis of the EuroELSO registry, but I will focus in the definition of infection, only microbiological criteria. Well, in this publication. On the other side, Justin as well and colleagues, they published in 2016 in the Assayo Journal a study focusing in nosocomial infection using a classical definition, CDC definition. So heterogeneity. I take this publication, I show this publication, French publication, because they introduce the concept of cannula infection. They do a proposal, I would say, combining again local signs of infection together with a positive culture in this study, in this group, taken via subcutaneous needle aspirate from the cannula site. This is a possibility, okay? And they describe it. I'm not going to the details because I don't have enough time. This is a last publication, very interesting. I recommend you to read it from the group, from Joseph, Aditya, Giles, and Graham. And they propose an algorithm for workup of infections in adult patients receiving ECMO. It's very interesting. I'm not going fully into the details, but the trigger for a suspicion of infection processes is, again, signs of focal disease. I think, and I agree with these authors that this is important. In this case, for this working group of these investigators, together with a decrease in oxygen saturation and hypotension. And if you navigate here, also you see here in case of urinary tract infection, they include dysuria also, which is a local, in this case, symptom of infection. This is another study from the group of Giacomo Grasselli and Vittorio Scarabelli. And I think it's a very interesting study, retrospective study of prospectively collected data, including 92 patients, okay? Adult patients receiving ECMO support. And they proposed definitions. And this definition of nosocomial infection is a combination between positive microbiological cultures together with clinical laboratory and radiographic data analyzed by 4 professionals. This is another option. This is another option. If I'm not going fully into the details here in this table, but they define bloodstream infection, catheter-related bloodstream infection, ventilator-associated pneumonia. Well, if you go here, ventilator-associated pneumonia, so these are cut points, I fully agree with them. But here, for example, clinical signs, to diagnose ventilator-associated pneumonia, for these investigators, you need 2 of these: fever, leukocytes, number change, purulent secretions, I agree with this, together with new progressive radiographic infiltrate. I would say this is difficult to be found, could be present, but difficult to be found, and worsening oxygenation. My point here is that there are several ways, different heterogeneous ways of approaching this very important complication of our ECMO patient, which is an infectious process, and absolutely we need an homogeneous definition. We have to establish definitions. And very recently, this paper has been published. This is related, obviously, with this topic, and I would like to share it with you. The publication in intensive care medicine from the Fundico project, conceived with the aim of developing a standard definition, in this case, for invasive fungal infections in non-neutropenic patients, in order to improve the generalizability, difficult word, generalizability and comparability of research results. Be careful, but this is important. The Fundico definitions have been developed for clinical research and not for clinical practice. And this is the start point. To me, this is the start point. So you can compare the information coming from this team, and even perform multi-center. Why not studies into this study? What they have done, this first, they have defined a multidisciplinary panel of experts from international societies. As a second step, they analyze the literature on the topic, and they put on the table a first possible definition for entities, and then they distributed this definition among the experts who rated it. I think this is perfect, and they in this step they were open for modifications from the experts. I would change this and so on. So it's a continuous analysis of the situation, and then they conclude with definitions, rank it as appropriate, possibly considered. This is a good way of analyzing a clinical field full of uncertainties regarding definitions, and this is pretty similar to our context, the ECMO patient developing, theoretically, sometimes developing an infectious process. And we have proposals from teams. This is the proposal from the Italian group. I'm not going into details again. Maybe down here, I can see it. Okay, now. ECMO cannula insertion site, pericatheter purulent drainage, culture it, perfect. Local erythema, local signs of infection again. And here, these colleagues, these investigators, they exclude common skin pathogens. This is a possibility, but to me, in my opinion, they for example, epidermidis, Staphylococcus epidermidis, they should be included, because there's some evidence suggesting that they have a potential for pathological, for creating pathological context in our patients, and it should be at least taken into account. In fact, the analysis we are taking, we are analyzing, we are performing here in Barcelona, we are finding the Staphylococci frequently. And this should be taken into account. If we went further into the clinical information, in some patients, you find leukocytes are up, fever, and even with outcomes. So at least it should be taken into account, maybe for establishing a diagnosis of a cannula colonization, okay? And this is a proposal we put on the table, obviously tributary to be discussed right now in whatever context. We think there are two core criteria, which are, again, microbiological information together with local signs or symptoms. In pneumonia, focusing on local signs or symptoms, pneumonia, the onset of purulent secretions or change in the characteristics of the secretions, or cough, increase or cough or start of cough of your patient, urinary tract infection, dysuria or pyuria, catheter, erythema or purulent secretion or pain, cannula, similar to a catheter, erythema, purulent secretion or pain, circuit, deposit of thrombi. This is frequently a manifestation of something going on in the oxygenator. To us, this is important. Bloodstream infection, no signs or symptoms of local aggression. So the absence is a condition for the diagnosis of bloodstream infection. A surgical wound, erythema, purulent secretion or pain. And the microbiological information, these are the cut points for the respiratory samples, the cut points for the urine samples. The catheter could be blood taken from the catheter, the catheter tip, the cannula swab of the insertion site, or sonication, but sonication, the problem is solved because the cannula is out. And regarding the circuit, blood samples taken from the oxygenator, the colonies should be 3 folds over a peripheral, the results of the analysis of the culture of peripheral blood sample. This is a proposal. And for bloodstream infection, 2 percutaneous blood samples, and for surgical wound, obviously a swab analysis and positive for any pathogen. So this is a must. These 2 criteria should be present, but also we should take into account other diagnostic supportive criteria that might be present or not, but its presence should be taken into account, maybe in creating scores. Maybe you give a number here, and this score is related with this possibility of the existence of an infectious process in our patients. Hemodynamic changes, again, changes, not static values, changes. Hemodynamic, such as tachycardia, hypotension, temperature, leukocytes, CRP increment, PCT increment, new bleeding or increased clotting. We frequently find this manifestation, only this. The patient, we have to take off the heparin, but the circuit is dirty. We have to increase heparin. These changes frequently is related with an infection process going on there. And also in observational studies, we should take into account if the clinician starts an antibiotic. It should be taken into account in this analysis. This is only, my friends, a proposal. So last slide, my dear moderator, to talk about the impact. Which is the impact of these processes, of these infectious processes? Which is the repercussion in our patients? We don't have if we don't have an homogeneous definition, the impact is difficult to say. It's difficult to say. But in general, it seems that infectious processes going on in the patient with ECMO support is related with a higher risk of death. This publication from Bizarro and colleagues, you can see here that the the mortality of the infected population was doubled. Here you can see here the odds ratio compared with the population receiving ECMO support who did not develop an infectious process. But again, remember that the definition was only microbiological definition. This is a review from Giacomo Grasselli and a group from Milano and colleagues, also reviewing the impact, the studies talking about the impact of nosocomial infectious processes in ECMO patients, in adult pediatrics and neonates, and this difference, the mortality among infected, is very frequently higher than the mortality in non-infected patients. And this is, I can't say a constant, but it's very frequent to be seen in the publications. Again, taking into account these non-well-defined entities. Again, this publication from Giacomo Grasselli and collaborators, including 92 adult patients who received ECMO support. Most of them received venous support. They found that the mortality rate of those patients who developed an infectious process was higher, significantly higher than the mortality of patients not developing a nosocomial infection. Also, you can see here in this graph, the white bars are those without an infection process, and here you find those patients developing an infectious process. So the ICU length of stay, the duration of mechanical ventilation, and duration of ECMO is higher in patients who developed an infection process. But be careful with this, regarding the causality. Probably this does not mean that if you developed an infection, you will stay longer in the ECMO. Maybe it's if you stay longer in ECMO support, for example, a COVID patient, you are at higher risk of developing a nosocomial infection. Okay? Be careful with this. Be careful with this. I don't have time to go further. Maybe later on in the discussion. And also the impact, I'm finishing, the impact is related, it's not the same, an invasive aspergillosis than a catheter-related infection. Infection is very general. And in this publication, they found that ventilator-associated pneumonia was associated with a high risk of death compared with no infection. But that was not the situation for other infectious processes. Again, low number of patients, but this is interesting. Also, the pathogen. They found that infectious processes due to a multi-drug resistant pathogen, those patients suffering these processes were at higher risk of death than patients without an infectious process. And that was not the case for those patients who developed an infectious process due to non-multi-drug resistant pathogens. This is important also. And I finish with this message. Also, fungal infections. You can see here it's not the other right. This is not statistically significant due to this low number of infectious processes due to fungal pathogens. But this is, you can see here the death rate of infection, and this is repeated among studies. Patients who develop infectious process due to fungi normally and very frequently are at higher risk of death than patients who do not develop. It changes between studies, the control group, the comparing group. But normally, if you clear it and you see it in the full picture, this is repeated here in this study from Justina Scholl and colleagues, fungal infection related with a higher risk of death. That was that final message. And these 6 messages, I would say they were the most important for you. But I am aware that we are running out of time. So I leave it for getting back to the moderator, stopping sharing my screen. Thank you.
Thank you, Jordi. I think there was a very convincing picture of the, you could say, rather lack of definitions than the existence of definitions in infectious complications in ECMO patients, and what the next steps could be with a proposal that you say is on the table and needs to be worked on within the working group and with a lot of experts. Thank you so much. usually we have a lot of attendance in these webinars. Today it's even much bigger, and I noticed that a lot of you came in just a little bit late. So I want to remind everyone that as a next speaker we have Marta Hernandez, who is an infectiologist from Barcelona, and she will give us insights into diagnostics and treatment and microbiological findings, most of all. And then Stephanie will give an interactive case as a microbiologist from Manchester. And for all of our time schedules, be reminded that this, as a kickoff event of the Infectious Disease Working Group of EuroELSO, is supposed to be a 90-minute webinar today. So for now, thank you so much, Jordi, and we are looking forward to have Marta as the next speaker. Please, that's your stage. Thank you.
Thank you so much. Can I ask if anybody can confirm that I am sharing the screen? Perfect. So this is a topic for me as an infectious disease specialist with many areas of uncertainty. And it's a pleasure to share with you all my doubts and limitations that we can find in the daily practice. I feel this as an extra opportunity to focus in what we know and what we don't know regarding microbiological findings, prevention, and treatment. I have no disclosures, and this is these are the part of the talk. These are the we will talk about microbiological findings, bundles for prevention, treatment, the problems and limitation, and finally the next frontiers. And to start talking about microbiological findings, we have to focus into two different kinds of infection in patients who are on ECMO. In the first part, we have this infection who are conducting to using ECMO for infection. And in the other part, we will talk about the nosocomial infections during ECMO and also the ECMO-related infections. And as you know, there are many microorganisms that can trigger respiratory failure or even cardiac failure that make us to use ECMO. Many individual studies examine different microorganisms that lead to ECMO. This can be viruses, bacteria, and even fungi. So all of them, when leading to severe acute respiratory failure, are a common indicator for using of veno-venous ECMO. But even in a small proportion of indication of veno-arterial ECMO, a reason is an infection. For example, myocarditis, or a sepsis-associated cardiomyopathy. So till to date, there is no specific infectious etiology that contraindicates using ECMO. But what we know is that co-infections have a worse prognosis. And regarding different populations, actually, a bone marrow transplant is no longer a contraindication of using ECMO. And even under certain circumstances, we can use febrile neutropenic, we can use ECMO on febrile neutropenic sepsis. So moving on the microbiological etiology, what we see here are different data from the EuroELSO registry. You can see in blue the using of ECMO for respiratory failure, and in red the cardiac failure. And these are data that are obtained by culturing patients prior using ECMO, respiratory cultures and bloodstream cultures. And I want to focus on these are data that we have to interpret with very, very carefully, because we cannot, as Jordi says before, we cannot distinguish between colonization and infection. And sometimes we can consider some, for example, Candida as an infection and it is a colonization. This is because a non-consistently and non-internationally accepted definition, as Jordi said in their previous talk. And of course, it can vary, the definition that we use to pick up the data inside the EuroELSO registry, it can vary between centers. So taking this into account, I want to remark that Staphylococcus aureus and influenza are the most common microorganism that we have to take into account in the veno-venous using ECMO, and also even in veno-arterial. And when we are talking about bloodstream infection, we have to remark Staphylococcus aureus and also Streptococcus. Of course, COVID had a role in using veno-venous ECMO, but we have not to take into account into this data due to the amount using of ECMO in COVID in the pandemic time. And the thing that I would like to focus is the good results that we have in ECMO associated to influenza. So, moving to nosocomial infection during ECMO, as you know, are the same nosocomial that we can see in patients with no use in ECMO in our ICU. And which are that? Well, ventilator-associated pneumonia, but also not associated to ventilator, urinary tract infections, and even bloodstream infection, but not related to ECMO bacteremia. You can see some examples. And when we are talking about the Euro-registry data, we talked about a prevalence of 21% of nosocomial infections in our registry. And this is an incidence of 30.6 per thousand ECMO days. But moving on the microbiological findings, this is a study, a retrospective study of the Italian group, the Milano, with a higher prevalence of using veno-venous ECMO. And as you can see here, they remark different types of nosocomial infection. Always normally in the literature, the most common infection is the ventilator-associated pneumonia. And as you can see here, the typical microorganism are Enterobacteria. And if we move to bloodstream infection, we see a very prevalent infection of microorganisms who are producers of biofilm, Staphylococcus aureus, Enterococcus, and even coagulase-negative Staphylococci. This is an important thing to take into account. I want to remark that there is a non-despreciable prevalence of multidrug-resistant bacteria. And the other thing that I want to share with you is this study. This is a Korean study. It's a very recent one, only published 3 months ago. And what I want to focus here is that near 800 patients using ECMO, similar proportion of veno-venous and veno-arterial ECMO. And this is a study that shows how the microorganism can change over time using ECMO. As you see in the previous days, the first days using ECMO, there is a high prevalence of Enterobacter cloacae or Escherichia coli. And even we use ECMO the more, there is an increase of prevalence in Candida parapsilosis, for example, or vancomycin-resistant Enterococcus. Talking about microbiological findings, but the impact on prognosis, we see here, this is also a retrospective study of 2016, and we can see here how the microorganism can change between survivors and non-survivors. They report here a higher prevalence of fungi, even Candida, in patients who died because of an infection or who died using ECMO. This is an important data to take into account because in this study, they do not define properly the difference between colonization and infection. So we do not know if these fungi, Candida and other fungi, are infection or respiratory aspergillosis colonization, for example. The other things are no significant difference between survivors and non-survivors in the other infections. This is also the Korean study, as you see in the right of the screen. This is the impact on prognosis of bloodstream bacteremia. As you see, patients with bacteremia and also candidemia, the most prevalent microorganisms are Acinetobacter baumannii and Klebsiella pneumoniae and Candida tropicalis and Candida parapsilosis. They die more when they have a bloodstream infection. This is an important thing to take into account. Finally, I want to focus that much in here because there are not a high prevalence of invasive fungal nosocomial infections, but I would like to share with you that we have to take this into account more if we are using ECMO in a COVID patient, because the management of invasive fungal infection is very challenging because of the biofilm formation, but also the renal and hepatic dysfunction, and also the unpredictable antifungal pharmacokinetics. And this is a study, a very recent one, who focused on this invasive fungal infection and venovenous and venoarterial infection, and they reported a prevalence of near 6% of Candida bloodstream infection. It's high, but not as high as reported before. And they really make the proper distinguish in between colonization and infection, in my point of view, because they compare with clinical data. And there is a prevalence of 0.5 of invasive aspergillosis. And you can see here how the prognosis, the survival impact when you have of course, invasive fungal nosocomial infection. And the hazard rate that they report for this was 2.5. Moving to ECMO-related infections, you know that these are the infections who affect of all the part of the ECMO. These can be the circuit, the pump, the bombing, the connectors, but also the heater cooler. As Jordi said before, mycobacterial infection had a very important role in here, but also the cannula infections, and of course, positive culture. But we have to focus between the difference between infection and contamination and colonization in these kind of infections. So ECMO-related infections are peripheral cannula insertion site infection, mediastinitis, and also persistent bloodstream infection. Persistent, it's a typical ECMO-related bacteremia. If we focus on the microorganism, I would like to share with you this study. This is a study from 2017, and I like this because they focus on the difference between colonization and infections. They study near 103 ECMO. It's a venovenous ECMO, and they classified the patients into three groups. Into three groups. Uninfected and uncolonized ECMO is one group. The other is the ECMO device colonization, and the other is the ECMO device infection. They divide the groups between that definition, a properly definition about regarding the microbiological findings for colonization and the microbiological findings, but also the clinical findings for infection. They correlated all the findings into a group of 3 intensive care specialists and 1 infectious disease specialist, and they defined every patient into each group. So they report a colonization rate of 32% and infection rate, very low, of 9.7%. And the ECMO device-related bacteremia was near 7%. There were no difference between groups regarding the outcome, and the main difference between groups was that the ECMO colonization group and the ECMO infection group had more time running ECMO. And these are the different microorganisms. As you can see in this part of the screen, this is the ECMO infected group. There is a high prevalence of negative coagulous Staphylococcus and reported Candida and reported Enterobacteria, and these are the colonization group. This is more biopsy. And these are the typical, and on the left, the typical bloodstream infection and cannula insertion infection. If we move on the microorganism of this CDC 2012 study, retrospective study that reported all the microorganisms that they found in the ECMO-related infections, they see that we see here the cannula infection are typical for E. coli, Enterococcus, Staphylococcus, and even Enterobacterius and Staphylococcus aureus. And in mediastinitis, there is a high prevalence of Staphylococcus epidermis, but also Candida. So these are the 75% infections per dozen days, and the more prevalent infection, nosocomial infection were pneumonia, as we said, and bloodstream infection. And the more prevalent were mediastinitis and cannula infection regarding ECMO-related infections. finally, I don't want to focus that much in the heater-cooler infections or colonization. The more prevalent is in colonization, and we have to remark the outbreaks in some European and American centers of Mycobacterium chimera. It's only a thing that we have to take into account that Mycobacterium, not only chimera, also abscessus, also Walensky, can colonize the water tank. If we to finish the talk in this area, if we focus on the risk of infection, we have to know that the risk of acquiring nosocomial infection, but also ECMO-related infection, is higher on veno-arterial ECMO than in veno-venous ECMO. This is because normally, when you have an veno-venous patient, you select the one correct patient, you do properly the nursing care, the medical care, and normally, well, not normally, but it's easier that a patient survive or the patient die. But when we have a patient on veno-arterial ECMO, every day is a cumulative risk of infection. It's like a time bomb. So these are the strategies that we have to take into account that impact in the risk of infection. The central cannulation strategy in veno-arterial, also the individual characteristic, immunocompromised status of the patient, all the rates, the reason for ECMO, but also the duration of ECMO is one of the most important risk factors of the risk of infections. You can see here this is a very nice graphic who shows that the longer you are on ECMO, the more likely you have infection. This is a curve of probability of being infection-free. So when you are in the beginning of the using ECMO, you have less risk of infection, but the more time you are on ECMO run, the most risk of infection. This shows that nosocomial infection, but also ECMO-related infection, is both at the same time are risk factors, but sometimes a consequence of a long ECMO run. Moving to prevention, one of the important focus to talk about is that we have these questions. Is there a role for antibiotic prophylaxis during cannulation or decannulation? Is there a role for obtaining routine surveillance cultures? Should chlorhexidine impregnated cannula dressing be used? Should there be a standardized extracorporeal life support infection prevention bundle? Well, as far as we know, there are many studies that have tried to prove the use of antimicrobial prophylaxis to prevent infection, nosocomial infection, but also ECMO-related infections. And no studies had demonstrated the benefits of routine use of antimicrobial prophylaxis. So also task force recommendation, it's not use antimicrobial prophylaxis, but many centers still use the antimicrobial prophylaxis. This is because one thing is what you write in a paper, and the other thing is to see the patient into the bedside, isn't it? I have found a study. This is 7,300 Japanese patients receiving ECMO that they tried to prove the utility of the use of cephalosporin and glycopeptide. They use teicoplanin during 48 hours within cannulation. And they show that this was associated with a lower mortality, with a risk difference of 3.7% in decreasing nosocomial pneumonia rate. But this is a tricky question because they do not report the use of antimicrobial treatment after the prophylaxis. So we cannot interpret this data as far as they show. What about the rest of the things regarding infection prevention? Well, use a chlorhexidine gluconate impregnated in the cannula dressings could help to prevent infection. There are not many studies, but some observational studies show this data. It's recommended avoiding use of alcohol. Other studies use prove the use of nasal decontamination, mupirocin, but also the oral amphotericin, colistin, and aminoglycoids plus chlorhexidine to body wash. They show less proportion of nosocomial infection using this bundle. And what about the cultures for every day of ECMO run? Well, this is what Jordi states. We have to have a low threshold to use cultures, and we have to interpret this onto the rest of the clinical data, because taking cultures every day could be time-consuming strategy and also not usable. Finally, I want to just make a summary of the global prevention bundle. As you can read here, there are some of them are like very logical, but we forget wash the hands, the clean wash. There are many things that we have to do into the catheter prevention strategies, but also the ventilator-associated pneumonia prevention strategies and the Clostridium prevention strategies. This could be a bundle that we can work on the next guidelines. And finally, I want to share with you this imaging, who are our colleagues from Valdebron, published recently. I think they can summarize all the prevention opportunities or strategies that we can use in ECMO nursing and medical care. We print them in our ECMO units at the hospital clinic, and we try to use every day with the new nursing and medical care sanitary health cares that are coming to the unit. Moving to treatment, these are the things that we have to discuss. What are the appropriate duration of antimicrobial treatment for ECMO-associated infections, but also ECMO-related? When, if ever, should cannula site be changed? And how are the pharmacokinetics and pharmacodynamics specific antimicrobials affected by extracorporeal life support? Well, as far as we know, there is limited evidence to guide the antimicrobial therapy in patients receiving ECMO. We know that there are differences between renal and hepatic function, and many times the patients who are receiving ECMO also are using renal therapy support. So no trials. So we do not know the optimal duration of treatment, and there is also a gap in the influenced by the absence of definition of infection. If we do not know how are the epidemiology, the microbiology of our infection, how can we know the best treatment strategies for our patients? This is a lack of data that impact also in treatment. One of the things that we know is that the cannula might contribute to new infection episodes, and we have to focus on the regarding the choosing the proper treatment. We have to take into account the biofilm active agents, for example, rifampicin or also quinolones for example, persistent bloodstream infections. But also another thing that we have learned is that the patient that we have, the patient that had bacteremia and also fungemia, due to a microorganism that can produce biofilm, for example, Enterococcus, Staphylococcus aureus, or Candida, sometimes experiment a recurrence after treatment, and this is because of the biofilm. So biofilm is a thing that we have to take into account regarding treatment. And also another thing that is very important is that persistent culture positivity is linked with high mortality. And this is a thing that we have to take into account regarding the using of one antimicrobial therapy or B therapy or synergistic combination or bactericidal and synergistic combination in patients who had for example, ECMO-related bacteremia or mediastinitis. Focus on the biofilm. You know that in the environment, biofilm is present everywhere, but in our patient, well, I don't want to focus because we are out of time. I don't want to focus on the essence of biofilm, but you know there are floating bacteria that can attach and form microcolony and maduration. And after that maduration, because of the adenosines and all the biochemical specific characteristics of biofilm, that can address to the device, and after that make a dispersion, disattachment, and focus, and even emboli in another part of this of the body. So in this patient, ECMO patient, where the ECMO cannulas, the removal is not the option, we have to take this thing into our mind. Other important part to talk about treatment is all the factors that influence pharmacokinetic alterations on these patients. The ECMO circuit factors, for example, the drug sequestration, the circuit priming, or the drug factors such as molecular size, electrical charge, or liposolubility, but also the patient factors, for example, acid-base disorders, or the volume status, systemic inflammation, organ dysfunction. All these things, as an infectious disease, we have to take into account in order to choose the proper antimicrobial therapy. We have to take into account the lipophilicity of the drug. For example, amphotericin and athols are high lipophilicity drugs, or the high protein binding, for example, such as echinocandins, for example. But also when the metabolism is hepatic or is renal, we have to take into account these. The patient factors and the binding site saturation, or for example, the ECMO circuit factors should be combined. And even when possible, the therapeutic drug monitoring should be taken into account. Finally, I want to say that as far as we know, the distribution volume is higher in ECMO in some situations, and also when we are using replaced renal therapy. And these are the trials, not only in vitro models, but also in vivo, make till the date regarding these drugs. Gram-positive daptomycin, cefazolin, vancomycin, teicoplanin, ceftaroline, and we have data from the rest of these drugs, but we still need more data. Finally, I want to end my talk talking about the problems and limitations that we have to date. We know that we have inconsistent definition of infections in patients with ECMO. This made that a lack of high-quality data on epidemiology and microbiology. Few studies on prevention, no data regarding multi-drug resistant colonization and consequence risk of multi-drug resistant infection. Limited data of pharmacokinetic and pharmacodynamic studies. We have some in vitro work, but we still need more. We have no trials comparing treatment studies and duration. Few prospective studies and no randomized studies regarding these subjects, and we have no international clinical guidelines recommendation regarding duration of treatment or the other things that we have to talk. In my opinion, the next frontier should be make a consistent definition. We can use some registry, EuroELSO, EDRA, that helps us to make a consistent definition, a better understanding on epidemiology from the group. We have this proposal from the Italian colleagues. More strategies for prevention and prophylaxis, and more study from PKPD and TDM. We have these two protocols ongoing, but we still have more work on this subject. We need to improve microbiological diagnosis techniques and make algorithm for imaging diagnosis, which is also a part of important to take into account, and know which is the multi-drug colonization and antimicrobial resistance in our patients. And when we have all this data, maybe we can do recommendation in antimicrobial treatment. Finally, a multidisciplinary approach to make a clinical guideline should be into the best way to try to answer all these questions. Thank you very much.
Thank you so much, Marta. I think you gave a great overview on the topic. You've given a quite pragmatic approach on things that we do on a daily basis, even though we don't really know on what to do best and what all the question marks are. And I think this adds a lot of weight on why this initiative and why this working group can be so important in the future. Thank you so much. While Stephanie is starting to share her screen, I would like to remind you that you can put in questions in the Q&A section of the Zoom tool. They will be answered in between by the speakers, or if there's time in the end, we can still have a very short discussion given the time, which is quite advanced at this point of time. So thank you for being here, Stephanie. We are looking forward to hear an interactive case, and I think this is a first-time event. Christian, correct me if I'm wrong. You will be able to answer questions that are handed to you by Stephanie. They will pop up in the tool and then be integrated in the further discussion of the case. Thank you for being here today, Steph.
Thank you. And just to confirm, can you see my slides? Okay. Great. I'm delighted to be here, and it certainly is a challenge to follow those two fantastic presentations. Thank you, Jordi and Marta, for the challenge. So I've got the task of running through a clinical case that we saw here in Manchester at the beginning of the year in December of 2023. So I'll introduce a 51-year-old man who was previously fit and well, presented to the emergency department here at Wythenshawe Hospital in Manchester with a 2-week history of a sore throat, a cough, looking unwell, sweaty, central chest pain, intermittently febrile at home, he told us, and was reporting rigors. And he was a little bit confused. He was just struggling to find words. He was tachypneic, tachycardic, but his blood pressure was stable and holding at that point. His white cell count was 1.3 and his lactate was 3.1. And his chest x-ray on admission showed a dense, patchy consolidation in a left lower lobe and some perihilar opacification on the right. So he was diagnosed with a viral pneumonitis with a probable bacterial superinfection. He was admitted under the respiratory team. He had a microbiology diagnosis screen, and he was started on IV antibiotics and IV fluids. His progress the next day, he remained very unwell and clinically unstable, and we had a positive result for influenza A at this point. He was in type 1 respiratory failure, needing high flow nasal cannula, and he was tiring and at obvious risk of a further deterioration. So the intensive care unit saw him as an outreach review and decided to admit him. So he was admitted to the adult intensive care unit here, and he was intubated and ventilated on admission, and his antibiotics were escalated up to IV piperacillin tazobactam, one of the broader spectrum gram-negative agents. His bloods at this point, his white cell count was 0.7 and his lactate was 5.7, and his chest x-ray was obviously getting worse. There was now a large left pleural effusion and new consolidation in the right side. And so because of this change, a CT thorax was requested because the team were worried about a developing empyema. And this was his CT report: complete opacification of the left lower lobe, some surrounding ground glass changes, multiple gas foci noted within the consolidated area of the left lower lobe. And it was unclear at this point by the radiologist if these were in keeping with cavitating changes in his chest. Progress day 3, he was getting worse. He was hypercapnic with a mixed metabolic acidosis despite being prone and intubated and ventilated, obviously, on the intensive care unit. His chest x-ray was worsening still. And at this point, the sputum that was taken on admission isolated Staph aureus, but the sensitivities were not available at this point. His white cell count was now 7, and his antibiotics were escalated to essentially sepsis doses of IV meropenem, and clindamycin was added in because of the Staph aureus. So question number 1, what's your management plan at this point? So question number 1 is, would you broaden the, I think you're sharing question number 2, apologies, Peter. Would you broaden the antibiotic cover? Would you keep removing fluids and keep him prone? Would you refer him for ECMO at this point, or would you do all of the above?
So let's have a few more seconds for the voting, still ongoing. And these are the boats you can see.
So,
Want to proceed?
yes, thank you.
If maybe one feedback, we can see the next animation already. You seem to be somewhere in the speaker presentation mode. If you maybe want to change it, we can see everything fine. We just can see two slides at the same time. If you can fix, that's fine. Otherwise, just keep on going.
Okay, I'll just carry on if that's okay. So the answer here is we did all of the above. We had another look at the antibiotics. We kept him prone and kept taking off fluid. And we referred him to the ECMO team. And this is where I stop talking realistically and let you read the slide, given the audience here. And I'm a microbiologist, so this is slightly above my pay grade. So I will let you read what we did. But essentially, he was transferred to the cardiothoracic critical care unit for VV ECMO. He had an uneventful cannulation, and they used a fem-fem approach. So lighthouse cannula, flows of 4.5 to 4200. And his oxygen saturation's increased at this point, and his temperature was set to 36 degrees, which is obviously important for us in the infection world. And then next slide again, I'll let you read. And the part here that is interesting to us in microbiology really is the TOE, because he's presented really unwell, and really septic, and he's a young man. And so one of the worries is this an infective endocarditis? So a TOE on admission is always really helpful. And so question number 2, is this patient an infection control risk, do you think?
Christian, I think we are one question ahead with the tool. So this is question 2 only. We had this before already. So I think the one you start.
Sorry,
now.
I will go back to question 2.
So give it another few minutes. Is this patient an infection control risk? Yep, okay, thanks. So if we can. So yes and no, actually, in this case. And the reason for that is influenza virus, as we know, is transmitted by droplet contact and possibly, we're still saying possibly, airborne routes. And so single room is appropriate for these patients with influenza A because of the risk of transmission. However, it's slightly different for ECMO patients, isn't it? Because we go back to what we're doing with these patients. We're oxygenating them in an extracorporeal circuit, but we're not ventilating them. Certainly not in the early stages when they are on rest settings by definition, so that we can rest the lungs. So we've got a patient that you're not really ventilating on rest settings with a closed circuit who is really quite unstable. And if I take you to my unit where we work, we have 6 side rooms, but they're all quite far away from the nurses' station, so they're down a corridor. So for us to put one of our most complicated, most unstable patients into the side room, it's a little bit, it doesn't really seem like the right thing to do, particularly when actually, if you think about what we've just said here, they're probably one of the lowest risk patients in the unit. So actually, we don't always isolate these patients, even with influenza A. And actually, I think it's probably somewhat dependent on your unit and the layout of your unit in terms of what you consider a risk and how you isolate, and if you isolate, in combination with your infection control team and your microbiologist and your infectious diseases. So question number 3, do you have any other concerns at this stage? This is a previously fit and well young man who has come in with a community-acquired pneumonia, yes, but a very severe community-acquired pneumonia, who has failed mechanical ventilation and needed ECMO. So what are your concerns? Are you concerned that this could be influenza resistance? Are you concerned that this is perhaps a hospital-acquired infection and he's developed a secondary infection on top of what he has? Are you worried about fungi at this point, given what we've heard? Or is there something just not quite right here? A few minutes to think about that.
Still answers coming in.
Of the 4 things, what's your biggest concern? Because it may change what you want to do with the patient. And I completely agree. There is something that's not quite right here. Thanks, Christian. We can close the box. So something's not quite right. So we have a young, fit and well man with a community-acquired pneumonia, yes, but he presented neutropenic and toxemic, really unwell and needed VV ECMO. Yes, he's flu A positive, but when we subtyped the flu, it was H3, which is seasonal flu. It's not pandemic flu. It wasn't something that was particularly more virulent. Yes, he's got a bacterial superinfection, but the only thing we grew on sputum is Staph aureus, and that, as we know, can be upper respiratory tract colonization. Interestingly, it came back to be resistant to clindamycin. So when we put the patient on clindamycin for that 24-48 hours, actually we weren't treating the staph at all. And he's got cavitating lesions on his CT thorax. So what is it that we're missing? And there is a test that we can do, and we should always do in these patients, that could help us in this case. And we did. We sent the Staph aureus for PBL toxin testing, and he came back as PBL positive. And so now going back to our infection control question, he's definitely now an infection control risk, both to the staff on the unit and to other patients. And there's some very nice guidelines from what was the Health Protection Agency talking about the diagnosis and management of PBL Staph aureus. However, these guidelines are from 2009. So PBL stands for pentanvalentine leukocidin. It's a very significant virulence factor and toxin that destroys white blood cells. And if we go back to his presenting symptoms, he was neutropenic on admission, and that's classic PBL until proven otherwise. These strains were first seen back in the 1900s when they were associated with staphylococcal skin abscesses. And there was one particular phage type, 8081, that seemed to spread quite widely. It was PBL positive and proved very successful in healthy individuals in the community, which again, if we go back to our case, we had a previously fit and well healthy man with a neutropenia and a toxemia, all fitting very clearly with PBL Staph aureus. PBL-SA predominantly causes skin and soft tissue infections, often can present with boils and abscesses, and patients often present with recurrent boils and abscesses, and they say, oh, I keep getting infected insect bites, and of course they don't. They've got PBL staph. And the very classic feature is that they present with pain and erythema that's out of proportion for any cutaneous findings. The problem for us in intensive care, however, is this organism can also cause invasive infection. And the most serious of this is a necrotizing or hemorrhagic pneumonia with a very high mortality still. Often follows a flu-like illness in otherwise healthy people. And of course, our patient presented with a prodrome, but also had flu. So the risk factors for PBL Staph aureus, as per the CDC guidance, it's the 5 Cs: contaminated items, close contact, crowding, and cleanliness and cuts and other. It compromised skin integrity. And often there is this history of going to the gym because it's this close contact sports where the close contact can spread this staph, which is sitting on the skin, from patient to patient. There's a very nice treatment guideline in these Health Protection England guidelines, which takes us through how we diagnose and how we manage Staph aureus. However, there are some slight problems for patients on ECMO. So if we start with the box that giving us some treatment options, this guideline tells us to start linezolid and clindamycin, and if deteriorating or features of severe disease, to add rifampicin. Now, any patient on ECMO is by definition deteriorating and has severe disease. So you could argue that any patient with PBL Staph aureus should, on ECMO and potentially on ICU, should have triple therapy. The problem is, again, these guidance were from 2009, and we've got lots of data since then to suggest that linezolid drops your rifampicin dose. Now, if we go back to think about what Marta's told us already about PK/PD studies and the problems with the circuit, we already have a problem with linezolid and linezolid dosing. On our unit, a number of years ago, we looked at linezolid levels and we couldn't get linezolid to therapeutic levels on a BD dosing. So all of our ECMO patients now, we give linezolid at the TDS option. So we're giving a higher dose of linezolid, which we think probably interacts even more with the rifampicin and will drop your rifampicin dose. The problem with that is rifampicin resistance in Staph aureus is by a point mutation, so happens very quickly. So if you've got a low dose of rifampicin because the patient's on ECMO, it's probable that your Staph aureus will become resistant very quickly. The other problem with linezolid, and particularly at high doses, is we know one of the significant side effects is thrombocytopenia. We see this a lot with linezolid, and of course most patients on ECMO have got low platelets. So my rule of thumb, our rule of thumb is we'll give it if the platelets are above 50 and we'll platelet transfuse and we'll just monitor, because of course the risk of thrombocytopenia due to linezolid is again bleeding, which is an additional problem to patients on ECMO where the bleeding risk is already high. The other issue with staphylococcal cavities is the duration of therapy. How long do you treat a patient on ECMO with Staph aureus in cavities in the chest? Do you want to treat until the respiratory tract is clear through sampling, or do you want to try and sterilise the cavity? And I'm not really sure that there is an absolute guideline to say how quickly you can sterilise a cavity in a patient on ECMO, because we don't really even know if we're getting therapeutic doses in. And the second problem with this guideline is this issue, and again, we've heard about it with source control, excluding complicated issues. If you've got a patient with a cavity or an abscess and an angioedema, the mantra from any infection specialist is treatment is source control plus antibiotics, and the antibiotics are often adjuvant to the source control. But of course, taking a patient to theatre with your getting your thoracic colleagues involved in an ECMO patient with the bleeding risk as it is often very, very challenging and often just doesn't happen. So these guidelines are a little bit out of date, I would say, and not overly helpful for ECMO. And the next point here is they say, again, with a deteriorated patient with severe disease, give IVIG. So my question to you is, how many of you would give IVIG to this case? And it can be quite difficult, can't it, to get IVIG, certainly out of hours. Depends on your pharmacy colleagues and the relationship you've got with your pharmacist, but how many of you would at least try to give it if you can?
Still answers coming in.
A nice split, and that's actually what I wanted you to say. Thank you, Christian. We can close the box, because my answer is yes and no, and actually it depends at what point you decide that your patient has got a PVL staph. If we go back to the beginning of this story, he presented with a white cell count of 0.7. So at that point, he had an immune system that was essentially failing. So my rule of thumb is, if you have a patient who's admitted with sepsis and the white cell count is low and falling, then I will boost the immune system with IVIG. By the time he got onto ECMO, his white cell count was 7.8 and climbing. So you could argue that the risk benefit from using a blood product like immunoglobulin is the risk is outweighed by the benefits, because his immune system is already constituting. So again, if you have a patient who presents with a white cell count of 20 and they're really unwell, they don't necessarily need IVIG. But if you have a patient with a really low and a neutropenic count on admission, and that's when you get in as quickly as you can and you give your first and your second dose of immunoglobulin to boost and support that immune system. So the other thing that was on the other question that was on our query concern is antiviral resistance, and are we concerned about antiviral resistance? On our unit, for patients who present with flu, we would always change the oseltamivir to zanamivir, and that's because oseltamivir is given by the enteral route and zanamivir can be given by the IV route. By definition, any patient admitted to the ICU with influenza is a complicated influenza, and we will always therefore have concerns with absorption in these patients. We have concerns with absorption in patients who are septic, and we definitely have concerns with patients who are proned. And you could argue that as soon as you prone a patient, you potentially lose your enteral route. And so it's possibly safer to just change to IVs rather than waiting to be told that actually the patient's no longer absorbing. There are some subtypes of influenza that are associated with resistance, and so you do need to link in with your infectious diseases and your microbiology, and particularly your virology team, because you do need to know what the dominant circulating strain is. And this is from the critical care influenza treatment guidelines. If your dominant circulating strain has a lower risk of oseltamivir resistance, i.e. seasonal flu, like our patient, then you can give oseltamivir, except in complicated influenza where you have problems with gastrointestinal dysfunction, which you could argue is any ICU patient. If you have a dominant circulating strain with a higher risk of resistance, like H1N1, which is pandemic strain, then it talks about going straight to zanamivir. But even in that case, I probably wouldn't suggest inhaled, particularly for ECMO patients. And so you could argue that it doesn't really matter what your circulating strain is. If you have a patient with a risk of poor absorption, then just go with IV zanamivir first line. Are fungal complications a concern, and at what stage? So on the 17th of the 12th, so a few days after admission, we had a BAL result that was positive, galactomannan positive at a level of 5.4. And the report tells us that an index value of greater than 1 is considered to be positive for galactomannan antigen and suggests invasive aspergillosis. And so next question to you, is this galactomannan BAL result, this single result, significant? And by significant, I mean, do you want to treat it at this point? And I suppose if your answer is yes, then just to consider why. If your answer is no, to consider why. And if your answer is, well, maybe, why?
And while you're all still thinking about this question, maybe, Steph, I can pass on a question to you that came from the audience. That I suppose there could be a very quick answer in between. Someone is asking, why not vancomycin instead of linezolid?
That's a really interesting question. And in the world of infection, we call vancomycin the hippopotamus of antibiotics because it's a really big molecule and it moves really slowly. So yes, vancomycin's fine, but if you want a really quick result, you need something with really good tissue penetration. And in this case, because we're dealing with a toxin-mediated disease, you need an antibiotic with antitoxin activity, and that's linezolid. So I wouldn't use vancomycin. I would use it in combination, but it's not your primary antistaphylococcal agent for a lung disease or a lung infection. So everybody's really said yes, and that's the answer that I wanted. Thank you, Christian. We can close the box. Yes, it is most definitely a significant result. And again, we go back to first principles of what we've seen. In this patient, you are oxygenating in an extracorporeal circuit, but you are not ventilating, particularly at the early stages of treatment. And so anything that the patient brings in their upper respiratory tract is going to stay there because they're not breathing it out. So what you have is, if the patient comes in with aspergillus, and it's not uncommon, you have aspergillus sitting in a nice, warm, moist, blood-stained, particularly with a PBL patient, particularly in a heparized circuit, blood-stained environment, which is beautiful culture media for aspergillus. And aspergillus is angioinvasive, so it can invade really quickly, and you can end up with disseminated disease. So aspergillus, an aspergillus result in a patient with flu on ECMO is a definite let's treat as quickly as we can. And this was a paper from our unit published back in 2018, which looked at adverse clinical outcomes in critically ill patients receiving VV ECMO with invasive pulmonary aspergillosis. And what it showed is basically that the median number of days on ECMO prior to aspergillus infection was 5. So this is quite an early onset infection, actually, probably because in those early days, the pathogens in the respiratory tract are sitting there. And of course, you're not going to bronch these patients particularly aggressively because of the bleeding risk. The paper showed that immunosuppression and influenza A were significantly associated with developing invasive pulmonary aspergillosis. And when you have pulmonary aspergillosis associated with influenza, of course, it's IAPA or influenza-associated pulmonary aspergillosis. So yes, have a really early index of suspicion in these patients and treat early. This is from the critical care guidance, seasonal influenza, which again talks about fungal infection. It says that CTs are not always helpful in diagnosing aspergillus because you can see nodules and cavities. We saw this in staphylococcal infection, so it's not particularly specific. It says in ECMO patients, speak to your essentially speak to pharmacists and experts on dosing, speak to pharmacists because they're great with dosing, and commence empirical antifungal therapy while waiting for the results. Don't wait for this organism to become invasive. Again, there's no evidence to suggest that routine prophylaxis is indicated, and so the best option really is to screen early on admission. Again, I won't go into this because we talked about it already and heard from Marta. There's many PK considerations in dosing and treatment. The really frustrating thing is the gold standard for Aspergillus infection is still voriconazole, and voriconazole is a lipophilic drug that's very highly bound and significantly sequestered by the circuit. So we would always give a dual antifungal. We'd start with ambisome and voriconazole until we can get the voriconazole levels therapeutic, which can take a few days. It can take up to 5 days. And then once we've got that vori therapeutic, because it's the gold standard, we can knock off the ambisome, but we give that dual therapy in the first few days. So back to our patient and our progress on ECMO. Day 13, he develops a presumed ventilator-associated pneumonia. No surprise there. You have to have a high index of suspicion, don't you? This is an old paper, realistically. It's from 2009, and it talked about this mantra of 10 days, this ECMO run of 10 days being associated with that risk, that cutoff. And in my world, we have an ECMO MDT every week, and if I'm still talking about the same patient at the second MDT, then I know that probably we are at the point where we're going to be running into problems with infection. Again, as we've seen, diagnosing infection is really challenging, and I won't go into any of this, but the diagnostic criteria really are so lacking in patients on ECMO because they're just not really appropriate, and they don't really apply. They're all thrombocytopenic, they're all temperature controlled, and they all have a raised CRP, possibly because of the circuit. So for me and for us, we kind of talk about small changes. Has the noradrenaline requirement gone up? Has the sweep gone up? If we are talking about a noradrenaline rise with a sweep increase, we're at second MDT and something's not quite right, again, it's infection until proven otherwise. Again, looking at treatment, it's the same problems really. Beta-lactams are our first line of treatment, and they are hydrophilic drugs, and they're significantly affected by hemodilution and other pathophysiological changes that we see during ECMO. So we give our beta-lactams in very high doses. So in this patient, we gave IV meropenem, but we gave 2 grams TDS, and that's what we do normally. And of course, we just give these high doses, monitor the liver function and monitor the renal function. So question number 6, day 17, and we have a positive blood culture, and it's a candida. So what would you do? And we've heard, haven't we, a lot about the problems with candida. So would you do nothing? Would you take some more samples and then have a think about it? Would you hold off treatment as an antimicrobial steward, repeat the blood cultures and see what the repeat blood cultures show? Would you immediately treat with voriconazole, or would you immediately treat with a dual antifungal? What would you do? And we're day 17 now. So we're in the 3rd week on the 3rd MDT. Or coming up to the 3rd MDT. So people thinking about it.
No idea why the results aren't shown, but treatment immediately with dual antifungal is 55%. Treatment immediately with voriconazole is about 18%. And take another sample is about 17%, and hold off treating is about 9%. Nothing is 0.
Interesting, great. So nobody would do nothing. So that's reassuring, isn't it? And actually what we would probably do is we would treat immediately, and we would treat with an antifungal, and we would, going back exactly to what Marta's talked about biofilm and the problems with biofilm, we would never consider a candida in a patient on ECMO a contaminant, even if the risk is there. The problem, as we've heard, is biofilm forms really, really quickly, and there's a really high risk for colonization of the circuit. And once you have a circuit that's colonized with candida, you're in really big trouble. So these are the IDSA guidelines from 2016 that we would still look to decide on treatment. We would probably give a dual antifungal with one of the agents with antibiofilm activity, like echinocandin. We would ask for repeat blood cultures until daily to check for clearance. And remember, day 1 of treatment is your first negative blood culture, because that's when you've confirmed clearance. We always ask for an echo. We always ask for an ophthalmology examination in week 1. And we would ask for you to change all lines and all urinary catheters at this point. We really need to get rid of this candida before it settles and before it seeds. The question, of course, is would you change the circuit based on this result? So I'll let you think about that for a second, and I'll go on to the next question, which is, you have done as you're told by the microbiologist and the infectious diseases team, and you've sent your repeat blood culture, and you get a phone call and a visit from your infection specialist, your infection doctor, to say actually the repeat blood culture is also positive and it looks like it's the same thing. So we've now got a problem with, do we have persistent positivity? Do we have a persistent candidemia and all of the problems that comes with? So what would you do now? Would you change the circuit at this point? Would you change the cannula? Would you change all your lines again? Because that's what the microbiologist told you to do. Would you stick with what you're doing? Would you try and do all of the above? Or are you not sure what you would do at this point? Candidas are tricky. Candida is tricky. It's probably not unsurprising that we've got Candida. Again, we're day 7 and we've not got this patient off ECMO. He's heading to a long ECMO run and we're heading to complications. Which of the 6 options would you choose now?
So again, no idea why it isn't shown, but all of the above is the majority with 55%. Maintenance treatment with 25, and change the circuit 13, and not sure about 8%.
Interesting. That's a really interesting split, isn't it? And this is a paper again from our unit that looked at the incidence of candidemia on prolonged venous ECMO. And what it showed, interestingly, is the incidence of candida increased throughout the run. So it's not surprising that we've got candida and persistent candida now, is it? Because the circuit has not been changed. And a little further interesting point from this paper was the window of continued risk continued after decannulation. So the risk for candida seemed to continue even when you take the pipes out in these patients. So if the risk of candida is associated with the length of the ECMO run, it's therefore associated with the length of the circuit and the age of the circuit. So we don't have, as far as I'm aware, any guidance to tell us when exactly to change the circuit, when to change the oxy, when to change the cannula, and should we? And again, this is all part of what we're trying to do here, isn't it, in the ECMO MDT. This is an interesting paper that was published very recently, last month actually, looking at monitoring oxygenator functionality and identifying key indicators and factors and considerations for change out. One of the points it makes is it's very much a multidisciplinary team decision, and it talks about lots of different parameters. The one thing it doesn't talk about, which obviously I noticed as a microbiologist, is it doesn't talk about the infective considerations. And should we be throwing this in as a reason to change the oxy? We change it when it looks clotted, don't we? We change it when there's an issue with the blood tests. Should we be changing the oxy or part of it if we have a positive blood culture? Would that depend on what the blood culture is, a candida, for example, or a Pseudomonas, because these are all associated with biofilm? And should we be saying that we change some or all of this, the oxy or the circuit, if we have persistent positivity? Should this be written into the guidelines? The problem, of course, is when do we say we change this? Because we know how unstable these patients are, and we know how difficult it is to try and get the right timing to change the circuit in these critically unstable patients. This is just a bit of data from our unit when we tried to look at what comes first. Was it gram positive? Was it gram negative? And what comes next? And we saw that candidemia seemed to come around day 19, which again would fit with week 3, wouldn't it? So could we then say that by the time we get to week 3, if we have a positive blood culture with a candida or a Pseudomonas or an agent that is producing biofilm, or a persistent positive, then we change the circuits or the oxy or the cannula. And can we, as in the number of centres, look at this between us so that we have bigger numbers and potentially inform when, if, how we change any parts of the circuit. So going back to our patient, and in conclusion, his progress on ECMO, he was treated with 4 weeks of high-dose linezolid for PBL Staph aureus. The rifampicin was started because he was really sick, and so we just followed the 2009 guidance, but we couldn't get the levels of linezolid to be therapeutic at that point. They seemed to be falling, so we discontinued it because we thought we were getting resistance. We did give him dual antifungals for IAPA. We had significant dosing issues. We started with ambisome. We continued with Vori until that was therapeutic. We gave him 8 weeks of treatment, and we imaged at the end of treatment, and he was followed up by our Aspergillus team because we have the National Aspergillosis Centre based at Wythenshawe Hospital. We give all of our patients acyclovir prophylaxis. That's our unit policy. And that was because a number of years ago, we were seeing a lot of reactivation of herpes viridae. All these patients are lymphopenic, so that is the risk for herpes reactivation. We saw HSV reactivated early in the ECMO run and CMV reacted late in the ECMO run. So now all of our patients get acyclovir prophylaxis until either the end of the ECMO run or until they're no longer lymphopenic. This gentleman was decannulated on the 3rd of January, which was day 22 of ECMO. He was a slow trachy-wean and he was stepped down to the ward at day 37 with critical care neuropathy and ICU delirium, which was managed by the ward. So in summary, and some learning points, when to suspect PBL staph, realistically it's clinically. So it's often young male, previously fit and well. There's a history of some kind of sport in many of these cases, with a prodrome, a toxic presentation, and importantly, a neutropenia. Often there's airway bleeding. We didn't see that necessarily here, but often there is. The chest X-ray often shows multilobe infiltrates at the beginning, and later we see cavitating disease. So in this man, we had all of those. Basically, we had a previously fit and well young man with a very severe community-acquired pneumonia who was more unwell than we knew really why. We think he had a primary viral pneumonia with influenza A, which will have denuded his upper respiratory tract mucosa, allowing invasion of these respiratory pathogens, leading to severe sepsis. His influenza was seasonal, so it wasn't a particularly aggressive type, but his Staph aureus was, because it was PBL toxin positive. And always remember, if you get a Staph aureus in a patient like this, send it for toxin testing and treat in the meantime. He had high galactomannan counts and BAL and cavitating lesions, which were suggestive of both staphylococcal infection and IAPA. And just as a reminder here that sepsis is a medical emergency and time is organ perfusion, and treatment time is of the essence. So in summary, patients with ECLS and infection, diagnostic issues are challenging and these patients are really sick. Pharmacodynamic and pharmacokinetics issues are real, which makes treatment incredibly challenging, and you do have to have a really good relationship with your pharmacy, your ICU pharmacists. There are no infection guidelines yet, I say, and it's most definitely an MDT approach, isn't it? And we definitely need more published data series and cases on these infective issues. And I'll just say thank you to EuroELSO for the invitation. Thank you.
Thank you so much, Stephanie, for what we could call a living disaster that you presented. But I guess that at least none of us may have seen all of that together in one patient, but all these issues you brought up are so practical and issues that we're dealing with all of the time. Now, you as expert managed to give all the answers to all the questions that came up. I would have so many questions that I won't give to you in the interest of time. However, I think what this session made very clear that it's so okay to have questions and it's so okay to recognize we don't have so many answers. And again, this is the reason why I highly appreciate that you started this initiative. And allow me only one question, and I will direct that to Jordi. How can we make sure that we don't miss any activities of the infectious disease working group of EuroELSO? What are the next steps? How can we connect, or how can we make sure to stay up to date with what's coming out of your group?
Thank you, Peter. Obviously, in an area of uncertainties, we try to create way of answering all the questions scientifically, obviously. And we do. We are trying to set up guidelines for clinicians in front of these infectious processes. We will start an effort to create multidisciplinary approach in terms of finding an homogeneous definition for these events, participation in congresses. I invite everyone to come to Krakow. This is the most important ECMO-related scientific event, I would say, during the year. So come to Krakow. There will be a slot for discussing all these infectious disease matters regarding the context of a patient receiving ECMO support. And for receiving the information of what we are doing, you have to visit the EuroELSO website. We will put there all the information. You can find there the standards of the working group. The working group is open to everyone interested in this field, independently of the profession, nurses, microbiologists, infectious disease specialists, and whoever is interested in this quite broad area of interest, because we do all this for our patients. They need this. They need this collaboration. So thank you, Peter, for giving us this space, and for all the 100 people attending this webinar. Please go to the EuroELSO website and contact us. We are there. We are same professionals as you are, and we are only pushing a little bit in through this area. I wouldn't say we are experts. We are only interested in this field. So the brief answer for you, Peter, is maybe EuroELSO website is the best way to see what we are doing.
Okay, thank you so much again for dedicating the time and for your great talks. Even though Jordi gave it a huge overtime in the beginning, your interesting talks made it possible that we lost less than 10% over the time. So I think that's a great achievement. Thank you to the attendees for joining. If you came in late, if you want to review something, all sessions are recorded and will be on the website in a couple of days. Jordi, you mentioned Krakow as our major event. Please come there. And if you want to suggest any topics for the EuroELSO webinars, please drop us a line. Thank you once again to all of you. And don't forget, you're only safe if your venous line is blue-berry and your arterial line is cherry-berry. And with this, goodbye. I see you next week, April 10. HS prognostic factor in VV and VA ECMO. It's going to be a great webinar. Please join again. Goodbye for today.